This is Dr. Jonathan Meyer, voluntary clinical professor of psychiatry at the University of California, San Diego, here to talk about using lithium in some special situations, such as women who are pregnant or later breastfeeding, older individuals, and some thoughts around what to do if you have to stop lithium. One concern for many medicines, of course, are their effects in the first trimester. And for lithium, the big bugaboo has always been cardiovascular anomalies. But before we get to that, let's just talk about bipolar disorder in general and pregnancy. Contrary to any belief you may have had, pregnancy is not protective for mood recurrence in bipolar disorder. Here's data from a wonderful study published by Adele Viguera in 2011, looking at a large number of pregnancies among bipolar 1 and bipolar 2 women. 23% had at least one mood episode during pregnancy, but much higher during the postpartum period, and you can see the figure on the right. Importantly, women who stopped their mood stabilizer had twofold higher rates of risk for any mood episode, and their time spent ill during the pregnancy went up fivefold. Also, if you abruptly stop the mood stabilizer, your median time to recurrence was shortened 11-fold. This is an instance where collaboration is really key. There are many women who require ongoing use of lithium for psychiatric stability. They cannot forego it for a trimester. Try to find an obstetrician who is familiar with the needs of patients who require lithium to avoid, again, the reflexive demand of many providers to stop the lithium. And most importantly, so that this person will arrange for the appropriate fetal ultrasound to look for cardiovascular anomalies in the second trimester. Another aspect of pregnancy, which many people are unaware of, is the improvement in renal function in the second trimester. The graphic on the right shows you declines in serum creatinine in the second trimester, and this is paralleled by an increase in GFR. The important take-home message is you have to monitor lithium levels in each trimester because they will probably become close to subtherapeutic, especially in the second trimester, and a dose adjustment will be necessary to maintain the same serum lithium level which was required for stability prior to pregnancy. But here's the thing that spooks people. It's the risk for cardiovascular malformations or CVMs, especially Ebstein's anomaly, which is a right ventricular outflow tract anomaly. A 2020 meta-analysis, which is referred to right here from the American Journal of Psychiatry, gave us the best data on this. And it's important that you be able to translate these numbers into something intelligible for the woman to understand. The number needed to harm for any cardiovascular malformation, comparing lithium users and non-users with bipolar disorder, was 83. And it's important that they did this analysis within the group of people who have bipolar disorder, apples to apples. Some papers try to compare bipolar patients with non-bipolar patients. Well, this is not valid. There's a lot of differences in these populations which may contribute to risk independent of the drug itself. But most importantly, this NNH, or number needed to harm of 83, means you would have to treat 83 women with bipolar disorder in the first trimester with lithium to get one additional case of a cardiovascular malformation. And even on those who are on high dose lithium, meaning more than 900 milligrams per day, the number needed to harm is 39. And that's from a US analysis, and the reference down there is from Patorno. The point being is that somebody needs lithium for stability. You let them know the numbers and reassure them that I would have to treat 39 if they're on high dose or 83 on lower doses of lithium to get one additional case. Many women will still not want to accept this risk, or they'll say, you know what, I did fine off of lithium for a few months last year. What are the other options? Well, antipsychotics are not associated with first trimester induction of major uh, malformations of any type. That's an option. May not be the same as lithium, but certainly an acceptable option. And also, in one of these studies where they looked at lithium and their rates of major congenital malformations, they had a large group of women exposed to lamotrigine, almost 2,000, and there was no increased risk. Now, the use of lamotrigine requires some advanced planning to get it up to a therapeutic level and then slowly taper off the lithium. But for some people, this might be an acceptable option to carry them through the first trimester. And then lastly, you'll always resume lithium in the second trimester, regardless of what happened in the first. As the time of delivery gets sooner and sooner, there is some evidence that women whose serum levels were under 0.64 tended to have more reactive newborns with fewer complications. Sometimes you can plan this, sometimes you can't. If you can't, it's not a big deal. You can't control when people go into labor, but if you have a sense of it's going to be a bit of time, you might be able to lower the lithium exposure a little bit just before delivery to make the newborn a bit more reactive. But importantly, after delivery, lithium has to be resumed. Lithium is significantly more effective than not being on lithium in preventing postpartum mood relapse. You can see the odds ratio is 0.16, meaning it reduces the risk sixfold. It's important to get people back on lithium as soon as possible, or if the dose had been lower just before delivery, get it back to the dose which had been therapeutic previously. Then as we get into breastfeeding, we are so fortunate that a paper was published in 2022 looking at longitudinal levels in both mom and importantly the baby during breastfeeding. The most important concept here is that in the first week, all the levels provided by mom. As the renal function matures, we do see some levels in baby which can be on the higher end, meaning 0.7, and you can see 1.2. But once you get past week 4, as the baby's renal function matures, the maximum level that was seen in any individual infant was zero point 0.2, and in many instances, it was undetectable. So how does one manage this? The idea is that in the first month, there may be somewhat more exposure. The way we will notice this is not that the level is toxic per se, but that some infants don't like it and they will feed more poorly. In those instances, you don't have to stop breastfeeding or you don't have to stop the lithium. Simply what you do is reduce the proportion of food which comes as breast milk from 100% maybe to 75% or 50% and supplement the rest with formula. Once you are past month 1, meaning you finish the first 4 weeks, you should be able to go back to 100% breastfeeding. As you can see, the median levels for the infants after month 1 are barely detectable. But in the first month, you may have to alter the proportion of breast milk and formula, and that seems to be the best way and the easiest way to manage the situation. Of course, we are concerned about the long-term effects of any lithium exposure in the baby, but we want to balance this with the idea of we're concerned about safety, but we don't want to have to phlebotomize the infant repeatedly. So below is a suggested monitoring scheme of monthly for the first few months, and then eventually going to every 3 months and 6 months. If there's any aspects of adverse effects, then of course you may consider getting levels sooner. But again, be mindful in the first week, the level is driven by mom's level. If you're concerned at all, you might consider getting an infant level on day 7, especially if mom had her dose increased to parallel what it was just prior to delivery. But the need to excessively phlebotomize the infant, especially after month 1, is not evidence-based. And this 2022 paper really provides us the best information to reassure moms that especially after month 1, lithium is very well tolerated and breastfeeding is indeed safe. As people get older, we have to manage a lot of things while they're on lithium. And one, of course, is their medical comorbidities, which may contribute to declines in renal function independent of lithium. So the first question is, does lithium work in older individuals with a history of mania? The answer is yes. This figure on the right was from a double-blind, randomized study of lithium versus divalproex. You can see not only was lithium equally effective, perhaps even a shade more effective, but importantly, it works. There's no question that it works. There's no reason to think that it doesn't work in individuals with a history of mania. The value of lithium, though, in the older bipolar patient rests in its neuroprotective properties. As you can see here from this meta-analysis in 2020, bipolar individuals have 3 times higher rates of dementia than their age-matched peers. The use of lithium, especially over a number of years, reduces the future dementia risk by almost 50%. 50%. And that's perhaps the most important reason to keep older individuals on lithium. And lithium is safe in this population. Yes, you have to monitor certain aspects. You have to be mindful of drug-drug interactions. But here's data from Ontario, Canada. 1,388 bipolar 1 individuals aged 66 and above who were discharged from a psychiatric hospitalization and followed for a year. And they were looking at medical events in the following year, comparing folks on lithium, divalproex, or neither of those agents. As you can see in the table on the right, there was no significant differences between lithium and Depakote-treated patients in the proportion with medical admissions, the time to any medical admission after their psychiatric discharge, or in the proportion with any non-psychiatric ER visit. When people did get admitted, the divalproex users had longer lengths of stay than those on lithium, but divalproex patients had fewer ER visits than those on lithium, although that result was not statistically significant. But the biggest predictor of the need for medical services in the following year had to do with prior medical hospitalization in the year before they were admitted for their mania and male gender. It wasn't the medication itself, and specifically lithium did not emerge any differently than divalproex in a number of these analyses. But the biggest risk is, of course, lithium toxicity, and it's not really due to the medical comorbidities or age per se. The biggest thing is the use of an interacting medicine. So this odds ratio of 30 comes from a study performed by the Kaiser Colorado Pharmacy Group, who found that among people who got admitted for lithium toxicity, an interacting medicine was by far and away the biggest reason. And this is why you have to collaborate with the primary care provider and let them know if you have to add any of a small number of medicines, almost all of which are antihypertensive, to somebody on lithium, please let me know so I can adjust the dose and recheck the level. Once you have that connection established, you can really help mitigate the problems with lithium toxicity. Other thoughts, of course, have to do with, can I continue lithium as the GFR declines, or can they actually start lithium in somebody with subnormal renal function? Approximately 10% of bipolar spectrum patients will have their onset from age 60 onwards. And some of these people will come in with GFRs below 60. The question always is, well, if it's below 60, is it even safe to start lithium? Well, we have an answer. This is a study which comes out of Sweden. They found that a sample of individuals who had mean GFRs of 54 when they started lithium with mean age of 55 and a half had no significant GFR changes over 7 years. Well, what distinguished these people was the fact that they did not have a lot of medical comorbidities. They had some, but lower burden. And as we know, a big aspect of the decline in renal function is not the lithium. Assuming you're giving it once a day, and the 12-hour levels are modest, often the biggest effect on renal function is the medical issues, the hypertension, the prediabetes, the diabetes. The nice thing about lithium is it has no cardiometabolic effects, so it's a nice alternative to atypicals. Some literature suggesting it might be cardioprotective, perhaps. Another thing that, though, in older people, especially if they've been on lithium for a while, is that they may get more brain penetration for any given level. A good example is somebody who tolerated a level, let's say 0.75 over time, and then as they get older, they complain of more CNS side effects. What's that reflecting is the fact they're probably getting more CNS penetration. This is an instance when you would actually start to lower their peripheral levels and explain to the patient they're getting more bang for their buck upstairs in the CNS for any peripheral level. And the fact they're complaining is evidence of that. And they may do just as well with a slightly lower level and have less CNS side effects. But sadly, there may be times where you have to think about stopping lithium, and typically it's going to be for lower levels of renal function. As you start to dip into that GFR stage 3B, which is 30 to 44 mLs per minute, the big thing, of course, is that we're worried about future declines. Again, a lot of this may not be driven by the lithium, but by the medical comorbidities. But As a psychiatric provider, I may have no control over their blood pressure or the extent of how their diabetes is managed. And we know that those things may continue to drive renal function downwards. And the big issue is we may just be losing our safety margin with the lithium. And there's a greater risk of lithium toxicity. So stopping lithium in this range may help stabilize renal function, even if there are medical reasons why it's going down, and also minimize the risk of lithium toxicity. But there may be people who say, look, I'd like to stay on lithium even though my GFR is in this range. And it's important questions. Can they actually do the necessary monitoring? I'm going to monitor these people very frequently, maybe even every 6 weeks. I want to make sure things are safe. Can they do that? And the other question is, do they have a compelling reason to remain on lithium with this low level of GFR? For example, somebody says, look, when I tried a non-lithium mood stabilizer like Divalproex, I was suicidal. I actually attempted suicide. Well, that's a reason to remain on lithium. It's important to look at all of these variables and come to a shared decision when you get to this point. And hopefully these are discussions which have been ongoing as GFR has been declining to give the patient a sense that there's some things to think about. Do you have alternative therapies? Do you have a compelling reason to remain on lithium? Can you do the extra monitoring for your own safety as your GFR is in this range? But if we get to the point we feel like, I have to stop the lithium, the most important lesson we've learned over the years, and this comes from papers by Ross Baldessarini, an emeritus professor at Harvard who worked at McLean Hospital for many, many years, is that you do not stop lithium abruptly ever. If you taper it off, even over a period of 30 days, you reduce the risk of mood recurrence time by fourfold, meaning you lengthen it fourfold. Give yourself some time to wean people off of lithium over the course of a month. It's really critical you do this. Partly you'll want to have something else on board also, meaning an alternative mood stabilizer when you peel away the lithium, but do not stop it abruptly. And part of the reason is we may see rebound effects, such as the increased risk of completed suicide may be 20-fold higher in the year after stopping lithium. And if you do this abruptly, that even doubles that risk. Not stop lithium abruptly, even over 1 to 2 weeks is too short. Extend that period of discontinuation to a month. After we stop the lithium, it may be hard to maintain the patient. We have data which shows that some people are simply preferential lithium responders. The graphic on the right shows the treatment failure with a number of non-lithium therapies, including combination mood stabilizer therapy. At times, we find that by stopping the lithium, maybe with better management of their medical comorbidities, renal function rebounds, and perhaps resuming it becomes more appealing, especially in the face of inadequate response with other therapies. And we can see the risk of treatment failure for many of these people was much lower when they were put on lithium compared to other therapies. This is something which you'll have to discuss with the patient. Of course, you'll have to take into account the other factors, but we certainly know that while we have a number of mood stabilizers, lithium works in unique ways, and some people may simply not do as well with other non-lithium therapies.